Hello. Hey, can everybody hear me? Can you guys hear me in the room? Okay, can you guys hear me on remotely? Okay, all right. My name is Sharif. I'm a gastroenterologist here at Erlanger. I've worked with a lot of you guys. I've not worked with some of you guys yet, but nice to meet you guys either way. Today, we're going to talk about colon cancer screening, surveillance, and management. This is one GI topic that I think is high yield for your guys' board exam. But also, is anybody here interested in doing primary care? I know primary care is not super popular anymore, so just a couple. But also, it's very important for the primary care practitioner, mainly because you guys are kind of the entryway into colon cancer screening. A lot of patients come to you, so you need to know which patients to refer for colon cancer screening and when. And so it's a good topic to review. By the way, you guys could just stop me at any point if you have any questions, okay? Spacebar. There we go. So I'm going to start today. These are going to be questions that we're just going to read for right now, but we're not going to answer quite yet. But these are questions that I want you to, these are questions you should be able to answer by the end of today's lecture, and also questions that you should be able to answer for your board exam, and if you work in primary care as well. So the first question, 47-year-old male, he has got type 2 diabetes and hypertension, currently well controlled with the medications that you put him on, presents for his annual wellness check. He would like to know when he needs to have a screening colonoscopy. He does not have a family history of colon cancer. What do you tell him? A, colon cancer screening is not required since he does not have a family history of colon cancer. B, he should have his first screening colonoscopy at age 60. C, first screening colonoscopy should be done now. Or D, he should have his first screening colonoscopy at age 50. So this is a question, basically, you have somebody coming in, when should they have a screening colonoscopy done? Question number 2. So if you guys have a little piece of paper, write down what you think the answer is, and then we'll answer it together at the end of the lecture today. Question number 2. 37-year-old female patient presents for her annual wellness exam. She tells you that her older brother was found to have a villus adenoma polyp during his first colonoscopy at age 45. What is the best next step in her care? A, she should do FIT testing now. FIT testing is fecal immunohistochemical testing. We'll talk about that. And do it annually until the age of 75. B, reassure her and advise her that her first screening colonoscopy should be at age 45 based on new guidelines. C, reassure her and advise her that her first screening colonoscopy should be done at age 40. Or D, she should have a colonoscopy now. Question number 3, 40-year-old male, no medical problems, gets a referral to have a colonoscopy done after his 83-year-old maternal grandmother was recently diagnosed with colon cancer. What is the next best step? Schedule a colonoscopy now and continue surveillance every 5 years if he doesn't have any polyps. B, schedule colonoscopy now and continue surveillance every 10 years if he has no polyps. C, reassure the patient and advise him to start screening at age 45. And D, reassure the patients and advise them to start screening at age 50. Okay. 4. 52, there's 6 of them, so only a couple left, guys. We're making it. All right, so question number 4. 52-year-old obese patient recently had a friend die from colon cancer. He is up to date on his screening colonoscopy and is next due for surveillance at age 55. He's still very anxious and he wants to know if there's any way to decrease his risk of getting colon cancer. Which of the following would not modify his lifetime risk of developing colon cancer? A, weight loss to a normal BMI. B, eating a diet high in fiber, fruits, and vegetables. C, developing diabetes at age 55. D, taking a probiotic with at least 100,000 colony-forming units per day. All right, question 5. 29-year-old male with a history of ulcerative pancreatitis, diagnosed at age 14, moved into town and presents to established care for primary care. He's on oral and rectal mesalamine, and he's been in remission for the past 5 years and does not feel that he needs to see a gastroenterologist currently just because he's doing so well. He does not have a family history of colon cancer. When should he have his next colonoscopy? So he should start screening at age 45. He should schedule a colonoscopy now. He should undergo fit testing now and annually until age 45, then start screening colonoscopies. And B, he should consider colonoscopy only if his symptoms relapse. All right, once again, we're going to go over these very same questions at the very end of the lecture. And question 6, 45-year-old has her screening colonoscopy for average risk colorectal cancer. Because she was average risk for colorectal cancer, she's found to have an 11 millimeter tubular adenoma at her hepatic flexure. What is the next best step? Colonoscopy in 3 years, 5 years. Counsel the patient about familial colon cancer risk, specifically about early screening for her first-degree relatives. And then D and E are both multiple answer choices. All right. So this, I'm just going to go over this very briefly. This is not super high yield for anything that you have to do in the future unless you want to be a GI fellow. But a lot of times you'll get a question from your patients about what is colon cancer? How does it develop? What is a polyp? Some people say a polyp is like a wart, but a polyp is not like a wart. It occurs differently. What you can tell that your patient is that a polyp is kind of an abnormal grouping of cells that has a defect in one of the genes that proliferates and then just becomes a larger grouping of cells. And over time, some of those grouping of cells can develop some cancer risk and become what's called an adenoma. And given enough time, those adenomas can also develop into carcinoma. So this is the adenoma carcinoma pathway. This is one pathway for colon cancer to develop. But once again, the details of these are not super high yield. The second type of polyp that we see that can also turn into colon cancer is a sessile serrated polyp. This follows a different pathway, the details of which is not super high yield, but just to know that there's a couple different types of polyps. Sometimes you'll have to help the patient read the pathology report, and it's good to know about these as well because the recommendations for surveillance after these are found is a little bit different. But basically, you start out with normal mucosa. There is a mutation in either the APC or the BRAF gene, depending on which one of these pathways you're following. And the end of that is going to be colon cancer. But all these develop over time, and it takes a long time for these developments to occur. A little bit about the epidemiology of colon cancer. It's the second leading cause of cancer-related death in the United States. It's the third leading cause for men, lung being number 1, prostate being number 2, colorectal cancer is number 3. It's also the third leading cause for women, lung once again being number 1, breast cancer being number 2. But because it's the third leading cause for both men and women, it actually, when you add it up, it makes it the second leading cause of all Americans for cancer-related death. There's about 148,000 new cases of colon cancer every year, and then 53,000 colon cancer-related deaths every year. The thing that's important about colon cancer is that it's thought to be medically non-curable. So if somebody has colon cancer, the only way to cure it is by doing surgery. And so that's why when we talk about colon cancer screening, why it's so important, because the only way we can cure these things with surgery is if we detect them early. From everybody who has colon cancer, about 80% of people with colon cancer have sporadic colon cancer, which means it just happens because it's the nature of the colon over time to develop cancer. Not in everybody, but in some people. 15 to 20% are familial, which just means that they have a family history of colon cancer, and 5 to 10% are inherited, which means that there's some sort of colon cancer genetic syndrome, like Lynch syndrome, FAP, which I'm not going to go into detail today, but it makes up for a very small percentage of the total number of colon cancers. The next thing I want to talk about is risk factors, because sometimes you get patients, they come in, they're really anxious and they want to know what are ways that I can change my life to like be at lower risk for colon cancer. The first thing you should tell them is they need to be up to date on colon cancer screening. That's the most important thing. But these are also risk factors that have been shown to have a ratio that increases, they've been increasing the risk of colon cancer if the patient has these. So if the patient has a family history of colon cancer, it actually increases their lifetime risk of getting colon cancer by 4 times. As the patient gets older, that's typically when colon cancers are diagnosed at an older age. It's very uncommon for them to be diagnosed at a younger age. Genetic cancer syndromes, Lynch syndrome, FAP is basically virtually you're going to get colon cancer if you don't get your colon removed. So some of these genetic syndromes also are higher risk of colon cancer. A uterosigmoidostomy, which is where the urologists divert the ureters to the sigmoid colon, that increases the risk of colon cancer actually in the sigmoid colon. And then certain countries, and we don't know why exactly, but in Hungary, South Korea, and Slovakia, they seem to have a higher rate of colon cancer than other countries. More moderate risk factors are if they've had polyps in the past, if they've had colon cancer in the past, the risk is still high to have colon cancer again. Young women with ovarian or uterine cancer at higher risk for getting colon cancer. So a good thing to know if you do have a patient like that. Patients with inflammatory bowel disease, Crohn's disease, ulcerative colitis are at higher risk for developing colon cancer. Dermatomyositis, acromegaly. I put it here twice, not because it's important, just because I forgot that I already put it. Dermatomyositis and acromegaly also increase the risk of colon cancer as well. And strep bovis infection is associated with colon cancer. You guys might remember that from USMLE step 1. We almost never see it. I've seen it once. And then more modest risks, and these are really the things that you can talk to your patients about. Having an unhealthy diet that's high in fat, high calorie. If you have diabetes or you're obese, you actually do have a 1 to 2 fold risk increase of getting colon cancer. Just like every other cancer, tobacco smoking doesn't really help in that regard. So tobacco and alcohol use increase your risk of colon cancer. Interestingly, if somebody's had a cholecystectomy, which is like pretty much everybody in Tennessee, I think, they are at higher risk of having colon cancer. If they've had prostate radiotherapy, so if they've had those radioactive pellets for treatment of prostate cancer, that increases the risk. And then within the Ashkenazi Jewish population, there is a specific gene mutation, which I don't think you'll ever be asked about, but it does increase the risk of colon cancer in that population. What are some protective factors? Just like having an unhealthy diet increases your risk for colon cancer, having a healthy diet high in fruit, vegetable, and fiber can reduce your risk with a ratio of 0.5, which is pretty significant. Regular exercise, being on a statin and NSAIDs in some cases has been shown to be protective. Having a diet that's high in antioxidants, folate, selenium, and calcium can also be protective. These are kind of less significant, but still something you can talk to your patients about if they really want to know one thing. So what impact does family history have on colon cancer? So can you guys see my arrow when I'm doing or not really? Oh, shoot. Sorry about that. I've been using it the entire time. Visible. Can you guys see it now? No, how do I make this visible? I can't click on pen. All right. So if you're looking at this bar graph, I apologize, and for you guys on Zoom, the general population has a lifetime risk of about 5 to 6% for developing colon cancer. Typically, if somebody's not screened, the average age of diagnosis is age 68. And so the one important point here is when patients come and you're talking to them about colon cancer screening, everybody's at risk for getting colon cancer. If you have a colon, you're going to get colon cancer possibly. So some people say, well, we don't have any cancer in my family for generations and generations. It doesn't matter. If the next bar over is first degree relative greater than age 50, that increases the risk to about 12 to 13%. If they have a younger first-degree relative, so that's the next bar over. So for instance, if they have a mother that was diagnosed with colon cancer when she was 48, that increases the risk to about 20% in lifetime. So 1 in 5 people with a first-degree relative who has colon cancer diagnosed at that young will also develop colon cancer during their lifetime. If you have 2 first-degree relatives, which is the next bar over, it's about 18%. So it's still very significant. If you have 2 first-degree relatives, so for instance, if you have a brother and a mother who have colon cancer, your lifetime risk is high. And as you might imagine, this is the last bar, if your mother and father both have colon cancer, your risk is over 30% of getting colon cancer during your lifetime. So this is another reason why it's very important to take a good family history, especially when it comes to colon cancer screening and risk stratification. This is another slide. I'm not going to get too bogged down into it, but basically, if you look at this, if you look at the chart here, the top line is family history, the bottom line is no family history. And so what this chart discusses is people with a family history, when in their life are they higher risk for developing colon cancer versus not, compared to those who are not. So if somebody has a family history of colon cancer, their relative risk is much higher around age 40 and 45 than it is when you compare the relative risk at age 70. So that risk kind of diminishes over time. As you get older, if you've made it all the way to 70 without getting colon cancer, can you still get colon cancer after 70? Absolutely. But compared to the general population, that risk is going to be roughly the same. So the important take-home point from this slide is that people with family history of colon cancer, their risk is highest at a younger age, between the age of 38 and 45. And so for them, it's going to be important to start screening them when they're at that younger age. That's the important take-home point here. All right. So colon cancer screening, this is where this is a more higher yield topic, especially for the ABIM. I'll discuss the importance of screening now. This is a graph from a study that was published, I think, with the U.S. Preventative Services Task Force. And it shows the effect of screening on the incidence and mortality of colon cancer. And we really started screening more aggressively in the 1990s. And you can see during that time, we've had a decrease in both the incidence and the mortality of colon cancer. So screening for colon cancer, it just makes sense. It does decrease the incidence, or it does decrease mortality. And if we can catch polyps before they turn into colon cancer, we think that's why it's led to the decrease in incidence as well. So this is from a study that was published in Gastroenterology. It was done at Kaiser Permanente in Northern California. And this is basically they did an intervention where they started to talk to patients more about colon cancer screening. That was done in 2008. So it's kind of small on my screen, but can you guys see that on the screen there? Where 2008 is over here on the right, where these lines kind of cross. And the red line is the percentage of the patients in that clinic that had their colon cancer screening up to date. So they made the intervention and more people became up to date on their screening. And then the blue line is the colorectal cancer mortality rates. And you can see that they dropped after they started implementing a screening program as well. The graph over here on the left, we see 2008 again. And that corresponds to this little spike in the graph here. And this is a graph of the incidence of colon cancer. And that little spike is because they started screening for colon cancer in 2008, right around that time. So after that, they started detecting more colon cancers. And so that's why the incidence spiked there. But then over time, as people continued with their screening program, that actually dropped off as well. So the importance of screening. What percentage of Americans currently do you think are up to date with colon cancer screening at this point? 20%, that's very pessimistic. Good, yeah, it's about 60%. It's a little bit over 60%. It's like 61, 62%. So 38% of people who are at risk for colon cancer are still not getting screened, and that's why colon cancer is still the third leading cause of cancer death. All right, so what are the different modalities of colon cancer screening? You should know this both for your ABIM and also if you're going to take care of patients in the outpatient setting. There's different tiers. Obviously, or maybe not obviously, but tier 1 is preferred. Tier 2 is okay as well. And tier 3 is if you can't do anything else. But colonoscopy every 10 years, if they don't have any polyps. Annual fecal immunohistochemical testing, which is a stool test that you guys can do in the office. You don't even need to send them to me. CT colonography, which is a special CT scan that people still have to do a bowel prep for, so I'm not sure why they do it. FIT and fecal DNA testing. This is Cologuard, if you guys have ever heard of that before. I'm not sure if you guys do that over at Dodson Avenue. And then flexible sigmoidoscopy every 10 years or every 5 years. This is like a half a colonoscopy where you only look at half of the colon. We don't do that really anymore. Some places, if they have general surgeons who are doing the colon cancer screening, sometimes they'll do it that way. So what is FIT testing? Fecal immunohistochemical testing. It tests for human hemoglobin. So if you have like a big juicy steak the night before, it's testing for human hemoglobin. That should be okay. It's a single small sample, and you're supposed to mail it within 24 hours of collection. So make sure you emphasize that with your patient. They shouldn't just, they shouldn't do it on Friday, mail it on Monday. They should just do it right before they mail it. It's gross to keep it in the fridge anyways over the weekend. But it doesn't require any dietary or medication restrictions. They can stay on their blood thinners. They can stay on their aspirin. It doesn't seem to affect the sensitivity or the positive predictive value of the test. So in that case, it's fairly convenient. Some vegetables have peroxidase in that, which can break down blood, but it doesn't seem to affect this test either. So this test is actually a really good screening test. It makes colon cancer screening accessible to everyone who can have a bowel movement, can do this test. The reason why that's important is because a lot of people are turned off by the idea of having a colonoscopy, so you can always make this test available to them. And actually studies have shown that when you give them the choice, hey, there's a colonoscopy, there's a Cologuard, there's FIT testing, more people get testing done. And at the end of the day, that's really the important thing. So what are the advantages? It's convenient. It increases participation in colon cancer screening. You don't need to change your diet or interrupt your medication schedule. It's highly specific for a lower GI blood source. So for instance, if you have an ulcer in your stomach, it's not necessarily going to set off a FIT test. The disadvantage is that there's false positives. Sometimes it's upper GI bleed. If that's large enough, if the upper GI bleed is large enough for that hemoglobin to escape degradation, sometimes it can yield a false positive test as well. But for a screening test, false positive is not necessarily the end of the world, right? It's much better than a false negative. Stool DNA FIT testing. Commercially here, the one that we use is called Cologuard. Okay, so hold on a second. So FIT testing every year. Okay, so if you have a patient that says, hey, I had a FIT test 4 years ago, not good enough. That's not going to protect them from getting colon cancer at all. They have to do that every year, or they should do something else. Cologuard, it tests for KRAS mutation. If you remember the pathway slide that we had earlier, that was one of the mutations in the development of an adenoma. It uses gene amplification for methylation biomarkers associated with colorectal neoplasia as well. And it also tests for blood. So it does a FIT test and then also a DNA test. Just like the FIT testing, there's no dietary modifications or medication modifications that you need to do. The only downside, the patient needs to submit an entire bowel movement for testing, which you can imagine the logistics of that might be difficult for some people. And once again, the specimen should be sent within 72 hours of collection. So it's always important to emphasize that to make sure that we're having a good test. And the reason why I'm focusing on these is because these are the ones that you guys are sending. these are the ones that you guys are doing with your patients in the clinic, all right? And nobody's going to send a patient to me to get a Cologuard done because it's a waste of time. But just to make sure that you're doing it the correct way. The advantages, the testing is done at home. It's every 3 years instead of every 1 year, like the FIT test. The disadvantage, the patient may be deterred by needing to collect an entire stool sample for submission. This graph shows you the sensitivity and specificity of the Cologuard and the FIT test. You can see that the sensitivity for colon cancer is 92% for Cologuard and 74% for FIT testing, which is still pretty good. It's better than nothing, but it's why we do it every year instead of every 3 years. The specificity is also pretty high, but I have to tell you guys, I've done a ton of colonoscopies for positive Cologuards and positive FIT testing, and I've almost never found colon cancer that way. So, so even though the data says that, I'm not sure why my practice experience is so different than the data, but not as good at ruling out adenomas though. So remember, advanced adenomas are large polyps that are well on their way to turning into colon cancer over the next several months to a couple of years. So not as good at ruling those things out. But if they come back positive, then it is pretty specific for an advanced adenoma. Virtual colonoscopy. So this is the CT scan. So sometimes you get a patient say, "Hey, I heard there's a CT scan that I can do instead of a colonoscopy." There is. It's tier 2. It basically makes a model of the colon, and you can see large polyps on there, and you can see colon cancer on there. But if you have a large polyp or a colon cancer, you still need a colonoscopy anyways. And you still have to do the bowel prep, which if you guys have ever talked to patients before is the worst part of a colonoscopy. So there's very little upside. I don't even think it's necessarily cheaper than a colonoscopy, but some places don't have colonoscopies available. So, but almost everywhere has a CT scan available. Septin 9. This is another thing I want you guys just to be aware of. This will not be on your board exam, and you guys will never order this test, but a patient might come in and ask, "Hey, isn't there a blood test that we can use to screen for colon cancer?" So Septin 9, I think, was one of the markers that was thought to maybe help screen for colon cancer. However, the one thing I want you to know about it is that it's an aid for helping, but you can't use it as a primary screening strategy. So you're almost never going to order this test. It's more ordered probably in research centers, but just want you to be aware of it. Okay, this is a table from UpToDate, which you guys can look at. I'm not going to spend too much time on it because we've already talked about almost everything that's on here. But a colonoscopy every 10 years still is the gold standard for colon cancer screening and prevention. FIT testing and Cologuard still have very good sensitivities for colon cancer. This is something that you can refer back to if you want to compare these different tests. All right. So those are the different screening modalities. Does anybody have a question? I'm kind of just chugging on here. So, but the basic take-home point, always offer non-invasive and invasive screening modalities to your patients. It's been shown to increase colon cancer screening participation. At the end of the day, that's the most important thing. So when do we start screening patients? I'll start with average risk patients. So someone who's at average risk, what does that mean? It means that they don't have any first degree relatives with colon cancer. They don't have any genetic syndrome that is placing them at risk for colon cancer. And they don't have inflammatory bowel disease, Crohn's disease, ulcerative colitis. So this is for most of our patients. The Multi-Society Task Force still recommends screening at age 50. African-American patients at age 45. That's been a change that took place a few years ago. You stop screening at age 75, and really this is individualized based upon the prospective mortality of your patient. So if you have like a 75-year-old that comes from a family where everybody lives until 110 and like runs marathons in their 80s and stuff like that, you can probably still continue screening them for colon cancer. The ACG, which is our society, recently changed it in 2021, and I took my board exam last year, and that was reflected on our board exam, which is an ABIM exam, just like your guys's is. But it's to recommend average age screening to start at age 45 or 50, but we're really moving to start screening at age 45, just because we're starting to see a lot of sporadic colon cancers in people between the age of 45 and 50. Once again, stopping at about 75, individualized for the patient. The NCCN, which I forgot what it stands for, but I know it's the oncology one. I apologize. Start screening at age 45 and stop screening at age 75 once again. So the take home from here really is you want to start screening your average risk patients at age 45. And if you have like an 80-year-old that comes in and he's like on a wheelchair or whatever, and he's like, I've never had a colonoscopy in my entire life, don't send him for colon cancer screening. It's too late. And also probably he doesn't have colon cancer. He's 80, he's in a wheelchair, and he's not symptomatic. All right, so what if people have a family history of colon cancer? This is another a point that I want you guys to pay attention to, because sometimes I get referrals for colonoscopy that are inappropriate. So I want you guys to follow these guidelines. So if somebody has colorectal cancer or advanced adenoma. So what do I mean when I say advanced adenoma? Because I've mentioned this a few times, I haven't talked about it yet. Do you guys remember from medical school the different types of colon polyps? Like there's tubular adenoma and villus adenoma, and then so there's that one, but that's not really, we talked a little bit about that, but it's still in the adenoma pathway is tubulovillous, right? So you got your tubular adenoma, your villus adenoma, and your tubulovillous adenoma. So any adenoma with villus histology, so it's your villus adenoma or your tubulovillous adenoma, that's an advanced adenoma. Those are higher risk for developing into colon cancer. Okay, it doesn't matter what the size is. If you have a tubular adenoma that is larger than 10 millimeters, that's also an advanced adenoma. Okay, so those are the three things that are advanced adenoma. If you have, we treat that like colon cancer when it comes to screening recommendations. Okay, so somebody with an advanced adenoma, for their family, we treat that as if they had colon cancer. Does that make sense to you guys? I know I'm trying to find the best way to phrase that. So if somebody has an advanced adenoma, their brothers, sisters, sons, daughters will be screened as if that person had colon cancer. Okay? All right. So if somebody has colon cancer or an advanced adenoma in a first-degree relative less than the age of 60, or multiple first-degree relatives regardless of their age. Okay? So this is the first category. Then that person should have a colonoscopy at age 40 or 10 years prior to the age of diagnosis for the youngest first-degree relative with colon cancer, whichever one comes first, and continue every 5 years. So if my dad has colon cancer diagnosed at age 47, when should I get my first screening colonoscopy? At 37, okay? Or if my brother had a colonoscopy for a rectal bleed at age 25 and they found a villus adenoma in his rectum, and I'm 40, when should I have my colonoscopy? Now, okay? So we treat advanced adenomas like we treat colon cancer when it comes to making recommendations for familial screening. All right? Does anybody have any questions on that? Okay. If somebody has colorectal cancer or advanced adenoma in a first-degree relative greater than the age of 60, so, you know, grandma had colon cancer diagnosed at age 83 because she had rectal bleeding. I'm sorry, or my parent had colon, not my grandma, so my dad had colon cancer diagnosed at age 83 because of rectal bleeding. I should start screening at age 40, but then I do the rest of the screening as if I was average risk. So instead of age 45, you start at age 40, but then if I didn't have any polyps, I could go 10 years. I'm going to go over the surveillance durations in just a second. Okay. So what if somebody has inflammatory bowel disease, Crohn's disease, ulcerative colitis? A lot of times you guys won't have to worry about this in your clinic, just because most of the times when somebody has Crohn's disease or ulcerative colitis, they're already seeing a gastroenterologist and we're taking care of it. But as you guys might be aware of, with your type 1 diabetic patients, sometimes people diagnosed with the disease when they're young, they're not the best at keeping up with it. And we see that a lot with our IBD patients. They do need to have a colonoscopy done with us starting 8 years after their initial diagnosis. Okay, if it involves, and this is a fine point here that you won't have to deal with, but if it involves more than a third of their colon, they should start screening with us 8 years after they're diagnosed. And the reason why is, if you take a look at these pictures, and once again, I'm using the mouse without realizing you guys can't see it, but if you take a look at the top set of pictures here, this is what a normal type of polyp looks like. It's kind of a larger polyp. It looks like it might have some dysplasia, but you can see it's raised above the rest of the colon. If you take a look at the picture underneath it, that is an area of flat dysplasia, and that's something that we look for in patients with inflammatory bowel disease. And they're at high risk for these things, and these things can turn into colon cancer just like polyps can. And so that's why we start screening 8 years after diagnosis, and depending on their disease activity and some other factors, we either screen every year or every other year. So they're on a very tight screening regimen 8 years after their initial diagnosis. All right, so important thing to know, because if you get like an inflammatory bowel disease patient shows up to your clinic who hasn't had a colonoscopy in 15 years, he's at risk for colon cancer. All right, any questions on that one? I know it's a little bit, you don't see it a whole lot, but it's still a good thing to know. So let's talk about surveillance schedules. This is the table you can always refer back to. The important parts of this table I want you to focus on is somebody has a normal colonoscopy, their next colonoscopy can be in 10 years. The guidelines changing recently really makes having between 1 and 4 polyps kind of a gray area. You're not going to be tested on it. But the one thing that I want you to know is if you look down about halfway through the table, an adenoma greater than 10 millimeters, so that's an advanced adenoma, or any adenoma with villus histology, they should be having a follow-up colonoscopy in 3 years. Okay, so if you have a patient that moves to town, he says, here's my last colonoscopy report, there's a villus adenoma in it, you need to make sure that they have a colonoscopy 3 years after that last one. The rest of it is kind of specific if you're doing gastroenterology, but the real take-home points here are if somebody doesn't have any polyps and their average risk, they can have their next colonoscopy in 10 years. If somebody does have polyps, it really depends on what type of polyps they are, how big they are, how many they are. But what I want you to focus on are the advanced adenomas. They require a 3-year follow-up after the initial colonoscopy. For Sesshaus-rated polyps, once again, a little bit specific for gastroenterology, but still good to know. If somebody has a Sesshaus-rated polyp, the follow-up's a little bit closer. It's 5 years instead of 7 years. But once again, if you look down towards the bottom half of the table, SSP greater than 10 millimeters, it's another 3-year follow-up, or if it has dysplasia, high-grade dysplasia, it's also a 3-year follow-up. All right, so bottom line, no polyps, 10 years at their average risk. If they have a large polyp, 3 years. Okay, the rest of it's probably going to be stuff that you'll send to a gastroenterologist to make sure they're on their proper screening for. I'm going to just skip over this table because it's kind of more details, more for the GI fellows. All right, so let's go back to these questions. Now I want you guys to answer. So this is the 47-year-old type 2 diabetic. He wants to know when he needs his first screening colonoscopy. What do you guys think? See, so he should have his colonoscopy now because the guidelines recently changed. People should start screening at age 45. He's 47. So excellent. And he's average risk because he does not have a family history of colon cancer. Okay. Question 2, this is a 37-year-old whose brother had a villus adenoma polyp during his first colonoscopy at age 45. What is the best next step in her care? Yeah, so she needs a colonoscopy now, okay? She didn't know about it. She didn't know her brother had a villus adenoma at age 35, but ideally she would have had her colonoscopy at age 35, right? What's another thing that's important for her brother to do at this point, since he had a villus adenoma at age 45? We treat that like colon cancer, right? So if he has any children, they need to screen earlier than age 45. They would start screening at age 35. Okay. I swear not all the answers to this question is do colonoscopy now. I know it's like very stereotypical gastroenterologist, but all right, question 3. So this is a 40-year-old whose grandmother, maternal grandmother, was diagnosed with colon cancer. We see this scenario a lot because a lot of times there's trauma in a relative being diagnosed with colon cancer. Everybody becomes their fear of it becomes heightened and they want to go get screened right away. So a 40-year-old, his grandmother, maternal grandmother, is a first-degree relative or a second-degree relative. Second-degree relative. So we don't really change screening guidelines based upon second-degree relatives having colon cancer, especially when they're diagnosed at age 83. So when should this person, or what should we do with this person? Right, C. Okay, so you should reassure him and let him know that even though his grandmother had colon cancer, general population lifetime risk is 5 to 6%. She was 83 years old. She may never have had a colonoscopy before. That doesn't increase his risk necessarily. All right, good. Sometimes we still do the colonoscopy because they just really want one, and insurance will pay for it, but we try to reassure them. All right, question 4. So this is a guy whose friend died of colon cancer, and he's up to date on his colon cancer screening, but he wants to know, is there anything else that would modify his lifetime risk? So if he lost weight to a normal BMI, what would that do? Decreases his risk, marginally, but it does. Eating a healthy diet high in fiber, fruits, and vegetables also decreases his risk, right? What if he develops diabetes at age 55? Yeah, marginal increase of lifetime risk. What if he takes a probiotic? Doesn't really, not anything that we know of at least. Probiotics, there's, if anybody ever asks about probiotics, patients, because they always ask me about them, I say if you take them and you feel better, then keep on taking them. If you take them and you don't notice any difference or you feel worse, then just save your money. That's the official stance on probiotics. So that does not modify the lifetime risk. Question number 5. So this is our 29-year-old veteran of ulcerative pancolitis, diagnosed at age 14. Ulcerative pancolitis means the entire colon was inflamed. If you guys remember from medical school, ulcerative colitis it's contiguous, but it can involve just a little part of the colon or the entire colon. So higher risk because he has pancolitis, and it was diagnosed when he was age 14. So that was 15 years ago. And he's not had a colonoscopy ever since he was diagnosed. So when should he have his next colonoscopy? What do you guys think? Yeah, no, okay. Once again, gastroenterologist writing a question. But no role for fit testing in these people. These people need colonoscopies. We need to be able to, and not only that, they need colonoscopies in people who have been trained to actually look for flat dysplasia, which we do here in our fellowship. So I do it here, but in some parts of the community, they don't do it. They'll refer to here or university to do a special type of colonoscopy. So you should definitely get the colonoscopy now. 6. So this is a 45-year-old. She was doing really good. She did her first screening colonoscopy at age 45, which is great. She wanted to have an 11-millimeter tubular adenoma at her hepatic flexure, which is the part of the colon up by the liver. What's the next best step? What do you guys think about A? A is good. How about B? Well, if A is good, B is not good, right? Okay. How about C? Because she has an advanced adenoma, right? She has a polyp that's larger than 10 millimeters. So she needs a 3-year follow-up, not a 5-year follow-up. How about C? Should we counsel her kids about getting screened early? Yeah, we should, because we treat advanced adenomas like we treat colon cancer when it comes to familial colon cancer screening. So in this particular question, the best answer choice is answer choice D. Okay. And the rest of this was for the GI fellows. All right, thank you. Does anybody have any questions? All right, is anybody here interested in GI fellowship? All right, good. Okay, so we have, you should come by, and our didactics are 7 a.m. on Monday. Don't do it, it's too early. But we do have, I'm joking, you can come. It's on Zoom, it's not that hard to go to. But we do have some research we're trying to get off the ground too. So just email me if you guys are interested in GI, and we can help you out. Okay. All right. Thank you guys for inviting me, and always never hesitate to ask me any questions if you have it.